So I'd like to move on a little bit about the next steps. And what do I mean by next steps? Well, we talked about local curative therapy. In a majority of cases, it works well. Probably well over 90% of the time, people stay disease-free for 10 years. But then there's that small percentage of people where their PSAs begin to rise, they develop recurrent disease, and or they develop what we call oligometastatic disease that we can't measure because we have limits within our technologies. And so my question to each of you, because I think you should each have a comment on this in a statement, because I think of the value, is what are our biochemical scanning options? You already talked about two new chemicals now with PET scans that have become approved that we can use, but we still have bone scan and CAT scan. So when should we do bone scans and CAT scans, and when should we obviate those for a PET scan?
I guess I'll start. I try to get PET scan imaging whenever I can. I think it's more sensitive, more specific than standard CT and bone scan. Reality is that insurance and payers it's moving so quickly, and frequently will be challenged. The payers won't agree to it. So we'll go back to CT and bone scan. But I think also, so I try to use PET as much as I can in the biochemical recurrent space, but also, this is very expensive technology. I think you got to look at it too, is this going to change my treatment management? Is this PET scan going to change how I manage this patient? Is it going to direct therapy? So we just don't want to just order the, latest and greatest test just to check it. We need to really have, specific questions we need to be answered, and how we're going to change our management based on those results.
Yeah, I think the other part to keep in mind is sort of this PSA doubling time. Those who are watching tonight who are very savvy with that know that it's not 2 goes to 4 goes to 8, but there's this complex formula that somebody figured out. And if you actually just put in, PSA doubling time, you get calculators. So if you're interested, you would put in the last 3 numbers and the dates that they were drawn. And I think the critical number that we try to figure out is whether the doubling time is less than 10 months or more than 10 months. When you sort of are in that sort of less than 10 months, you start to worry that this is a pretty aggressive cancer and that it's probably going to show up on traditional imaging much sooner, so that you're not trying so hard to say, gosh, where is that area that's causing this PSA number? If it's a long time, like let's say your doubling time is 2 years or 3 years, I'm not sure if any imaging is going to capture that. It just means that cancer is not doing much. There's also data to show that, the whole number matters. So many of you can calculate this, but if you're going from 0.02, to 0.06, you're probably not going to see anything. Just the resolution on these scans are just not that great. Even with a PSMA or the Axemin, 0.2 is something that is sort of batted around as a bare minimum number to see. So I think there's other factors in there. And I agree with Jason when you say, well, what are you going to do with this? If you're going to say, well, I really want treatment, and that treatment is an injection of Lupron or some, what we call androgen deprivation, then you have to think hard if that's really what you want to do at that level, knowing that there are, treatment side effects, or is this an opportunity to figure out if there is a clinical trial, around the country and also locally. There's many. So at Hermanos, we have a trial with muscadine grape extracts, all the way to the newest immunotherapy and PARP inhibitors. So you're talking about a spectrum of here's some almost nutritional products to the latest PARP inhibitor plus an immune therapy. That's a huge gamut, but they all have sort of one thing in mind and in common, which is how fast is that doubling time? So one of them really wants you to go on at less than 6 months doubling time. That's a pretty quick doubling time. And the other one is, less than 10 months. So there's a sense of, I think, as you're thinking about how the pace is going, that if it's really starting to rapidly rise, go contact your doc and say, what do you think?